So I want to thank everybody, especially the Ogden Surgical Medical Society, for inviting me to speak this morning. I recognize that I'm being invited to speak first because the musculoskeletal system is the most important organ system of the body. I'm sure that's why I was invited to speak first. I'm going to speak to you today about what is new in joint replacement factors affecting outcomes. I reached out to many of you before I prepared this talk, and I asked questions, what would you like to hear about? And I got a wide variety of responses. What you're going to hear today, I decided to do was give you a breadth of information rather than take some narrow subjects and go into some detail. So I want to share with you a lot of information today, this morning. Hip and knee arthroplasty is among the top 5 surgical procedures by cost and volume. In multiple studies, hip and knee replacements are regarded as a great value. They improve quality of life, lengthen employment, and increase earnings as arthroplasty recipients are able to remain in the workforce. Improvements in technology and techniques have made these procedures steadily safer and reliable. By 2030, the U.S. population will be 359 million, and the projection is that 635,000 hip replacements and 1.26 million knee replacements will be performed annually in the United States. It's estimated that 1 in 12 adults over the age of 25 will have a knee replacement in their lifetimes. What are our shared goals? We want to improve the health of populations. I want you to think of the musculoskeletal system as you would any other organ system, such as the cardiovascular system, pulmonary, endocrine, neurologic. The musculoskeletal system is privileged, however, in that exercise has been shown to benefit all other organ systems in the body. We want to improve the patient experience through empowerment, education, and efficiency. We want to reduce the per capita cost of healthcare. The U.S. has the most expensive healthcare system in the world, and financial pressures are a reality. What are my goals? My goals in arthroplasty surgery is what I refer to as the Holy Grail. Unrestricted function. I want people to go snow skiing. I want them to play pickleball. We want survivorship. We want to do it one time, do it well, and be done. And a new concept coined in orthopedics is called the forgotten joint. Approximately 20% of people receiving knee replacements express some dissatisfaction with their knee. We also want to reduce complications. We want to optimize preoperative, intraoperative, and postoperative factors to reduce morbidity and mortality. The primary mortality after arthroplasty is from venous thromboembolic events. Reasons for revision include chiefly infection, instability, loosening, fractures, stiffness, and failure to relieve pain. Patients who receive a knee replacement before the age of 65 have a 6-fold increase risk of revision compared to someone who receives a knee replacement after age 75. Who is responsible for preparing our patient for surgery? Ultimately, it is the surgeon's responsibility, but many people play a role. In our community, it includes the primary care physician, preoperative anesthesia screening programs, a coach, a family member, or a friend, and there are many online resources. The list of modifiable risk factors for arthroplasty surgery is extensive, and we need to recognize these modifiable risk factors and stress the value of them to our patients. Patients need to understand the potential complications and be invested in the process for a safe and successful joint replacement. One of my favorite books is In Defense of Food by Michael Pollan. The first line of the book is, quote, "Eat food, not too much, mostly plants." In the second sentence of his book, he apologizes for revealing the conclusion so early and says, "You can read the book further if you want." Well, today, I'm going to spoil the remainder of my talk by saying this. Patients considering hip or knee replacement need to be as healthy as we can get them. It's that simple. Communications between physicians is central to collaboration. We have busy practices and work in a fragmented healthcare system. But if there's something important to communicate, please call. Risk stratification systems are helpful, but they have limitations and are not widely used in non-academic practices. There may be hundreds of variables, and there is a lot we do not know, such as, are certain risks synergistic? Unfortunately, at the present time, our risk stratification relies heavily on human experience. And the question is, who determines if the patient is an acceptable risk? For example, having a hard stop for a body mass index of 40 or greater deprives some individuals of a procedure which could greatly enhance their lives. It is important to identify and improve modifiable risk factors, but the ultimate question is this: it is reasonable to ask for improvement, but is it ethical to require it? We need to provide a humanistic approach to care, recognizing that each patient has a unique set of expectations and pressures. The surgeon is the ultimate arbiter of risk and benefit for his patients, but must engage them in shared decision-making. Who in this group is not eligible for knee replacement? Patient on dialysis, 3 liters of oxygen, insulin-dependent diabetic, or mechanical heart valve with anticoagulation? And the answer is none of the above. I've done joint replacements for all these individuals in our community. We know the benefits of exercise are huge, and the body of evidence connecting exercise with wellness grows yearly. Please encourage your patients to stay as active as possible before and after surgery. Once a patient selects a day for surgery, we obtain a basic set of routine labs within 30 days of the procedure. Abnormalities with these labs may result in a hard stop and a surgery cancellation. Expanded labs may be appropriate to optimize the patient's health status. Abnormalities of these expanded labs have all been correlated with increased complications, and there are likely many more that we have yet to discover. The most common abnormal labs that we receive that result in a case cancellation include an active urinary tract infection, newly discovered renal insufficiency, anemia, a hemoglobin A1C of greater than 8. A hemoglobin A1C less than 7 is preferred. Between 7 and 8 is somewhat of a gray zone. Patients undergoing arthroplasty have a higher body mass index, and this has not changed over the past decade. However, obesity as a percentage of the population has increased over the past decade. An article in May's Journal of Arthroplasty predicts that by 2030, greater than 46% of the general adult population in the U.S. will be obese or morbidly obese, and 55% of primary hip replacements will be in obese or morbidly obese patients. So I have an obesity quiz for you. Are obese patients undergoing knee replacement, hip replacement at increased risk of complications? I think it's a no-brainer. The answer is yes. There's an increased risk of there's an increased risk of wound dehiscence, superficial deep infection, and reoperations. Interestingly, however, there does not appear to be a correlation with cardiovascular events or thromboembolic events. There was a landmark study in 2014 by John Insall evaluating complications after patients with a body mass index of 40. He examined 1,770,000 knee replacements, and he had 90,000 patients that met the criteria as morbidly obese without comorbid conditions, and they were compared to matched controls. What was found is that patients have an increased risk of in-hospital mortality, greater length of stay, greater likelihood of being discharged to a skilled nursing facility. Do obese patients who lose weight in the months immediately prior to hip or knee replacement decrease the risk of complications? The answer is no. In fact, the data shows they are at an increased risk. This is believed to be due to uncontrolled weight loss, leading to sarcopenia and some relative malnutrition. So if you have a patient that's trying to lose 25 pounds in 6 weeks in preparation for the knee replacement, the advice is tell them not to do it. Do obese patients lose weight after hip or knee replacement? Not usually. 65% of obese patients fail to lose weight after surgery. And the last question, does bariatric surgery prior to arthroplasty decrease risk of complications? The answer is it's complicated. Some studies suggest that better results after bariatric surgery, while others show little or no benefit, and still other studies show an increased risk of complications. Despite the health benefits of bariatric surgery, it does not seem to confer a reduction in complications in knee replacement recipients. There is an association with increased dislocations, revisions, worse implant survivorship in hip replacement patients. There's a belief that this may be due to soft tissue laxity in the setting of weight loss or due to some underlying metabolic and/or collagen abnormalities associated with bariatric surgery. Overall, obesity is proving to be not as reliable of a risk factor as previously thought. People have difficulty losing weight prior to and after surgery, and weight loss in preparation for surgery may not confer as much benefit as once believed. Traditionally, orthopedic surgeons focus on optimal implant material, surgical technique, and postoperative rehabilitation to ensure optimal outcomes. However, it is now recognized that optimal postoperative recovery after hip and knee replacement may depend on psychologic factors. It is common to see psychologic pain manifesting as musculoskeletal pain. Depression and poor emotional health predict dissatisfaction and functional outcomes 1 year after hip and knee replacement. In the orthopedic clinic, it is now reasonable to ask patients questions such as, do you find yourself anxious or depressed? Are you under financial stress? Are you having any difficulties with your spouse or significant other? Pain out of proportion for what is expected is a red flag. We know that 20% of patients undergoing knee replacement express some degree of dissatisfaction, but the question is why? Metal allergies have always been a concern, but the topic is highly controversial. While alternatives to traditional implants do exist, if allergies are suspected, we simply do not have enough data to give recommendations. There's no indication for preoperative allergy testing, metal allergy testing at this time. We can extrapolate from history, however. Traditional hip-bearing surfaces were metal on polyethylene. We went through a phase of metal-on-metal articulations 10 to 15 years ago because it afforded some benefits, but the immunologic responses to polyethylene debris and metal debris were found to be vastly different. Some metal-on-metal hip adverse local tissue reactions merely resulted in pain, resulting in revision surgery, while still others resulted in extensive tissue destruction called aseptic lymphocytic vasculitis-associated lesions, or ALVAL. So the science regarding metal allergies is not settled at this time. Eliminating fatal pulmonary embolus remains a challenge. In 2008, the CMS labeled DVT and PE as never events. However, we continue to see fatal PE rates of 0.2% for knee replacement and 0.4% for hip replacements. The goal is balancing a reduction of thromboembolic disease while mitigating surgical complications associated with anticoagulants. All of our strategies to prevent VTE attempt to manipulate the components of Virchow's triad. Modern surgical protocols and thromboprophylaxis have reduced DVT rates, but not PE rates. Past chest guidelines pushed prescription anticoagulants for all orthopedic patients. This resulted in increased bleeding events, returns to the operating room, and higher rates of infections. Coumadin, which was the gold standard for many years, was shown to increase the risk of bleeding events, returns to the operating room, and infections. For these reasons, orthopedic surgeons returned to using aspirin as a preferred pharmacologic prophylaxis in low-risk patients. Our current fatal non-pulmonary embolism rate is about 0.5 to 1%, and our fatal PE rate is as noted. Patients undergoing knee replacement and hip replacement have the highest overall risk of venous thromboembolic events. There's no evidence of different risk profiles between hip and knee patient recipients. The key thing to remember is in orthopedic patients, intravasation of marrow fat when we manipulate the intramedullary canals of long bones is the strongest known stimulus of thrombogenesis. Depending on what guideline you use, we now stratify patients as either low, medium, or high risk, or sometimes merely low and high risk. But there is no consensus for the optimal risk stratification algorithm. There's no consensus on who is low, medium, or high. Furthermore, the greatest limitation of these risk stratification protocols is even after appropriately identifying patients as low, medium, or high risk, the optimal prophylactic regimen in these patients has not been determined. Selecting a prophylaxis agent should be determined on shared decision-making with the patients, balancing the risk of venous thrombosis versus bleeding. The optimal pharmacologic agent has yet to be determined. Aspirin is now recommended for patients who are at mild to moderate risk. Direct oral anticoagulants are now widely used for ease of administration. For those at high risk, Eliquis has been shown to have the lowest post-op bleeding risk, but there are barriers to its use, and those are chiefly cost. Many of the patients we identify as high risk will express some difficulty in obtaining the medication or will be unwilling to pay for it. Historically, we've had three categories of knee replacements: cruciate retaining, cruciate sacrificing, and posterior cruciate substituting knees. In all of these cases, the anterior cruciate ligament was sacrificed. Knee replacements done in 2019 were split evenly between PCL sparing and PCL sacrificing designs, but the trend over the last few years is to use more PCL sparing designs. One has not been proven to be superior to another. During this time, implant sizes have also expanded and has resulted in better stability and better range of motion. The medial congruent knee replacement is a PCL sparing knee, which was developed to more closely mimic the kinematics of the normal knee. If you remember the concept of the forgotten knee, we're trying to improve upon patients' comfort, and so they feel that their knee feels natural to them. Although very successful, a traditional knee replacement results in greater activity of the quadriceps, called a quadriceps active gait, and we have been unable to reproduce the normal rolling and gliding motion observed in the normal knee. The medial congruent knee has a different polyethylene or plastic bearing surface and was developed to produce more normal kinematics and a more natural feel. In the medial tibial plateau in the slide to your left, you'll see in a normal knee, the medial femoral condyle does not roll back and it maintains a point of contact very small. But on the lateral plateau, there's more of a rolling and gliding motion. And the medial congruent knee has a very deep dish on the medial side to try to mimic this rolling and gliding on the lateral side and pivoting on the medial side. The only thing worse than infection is a compromise of the extensor mechanism. 90% of patellas were resurfaced in the United States in 2021, but there's no clinically significant difference in pain or gait. In Sweden, only 2.5% of patellas were resurfaced in 2021. When you resurface the patella, you can have a poor position, you can have it increases dislocations, and it's a stress riser and can produce patella fractures. The alternative is not to resurface the patella. It's faster, patients have the same motion, same function, and reduced complication rates. Peak pressures on the patella are less and the contact area is greater if the patella is not resurfaced. A Stanford orthopedic surgeon never resurfaces the patella and says that in the last 6 years, it has been the single greatest improvement in his practice of knee replacement surgery. Your slide on the left is a standard knee replacement where the patella has been resurfaced. The one in the middle, the patella is markedly eroded. There's minimal bone stock, and the question is what to do with it. And the best thing to do is leave it alone. Don't resurface it, remove the osteophytes, and move on. And the patient to the right has a prior history of a prior ACL reconstruction, has post-traumatic arthritis, but is young. So as to eliminate a point of potential failure, try to improve survivorship, the best thing to do for that patient is not to resurface the patella. Surgical approach to the hip. No one wants to talk about it anymore, and there's no clear winner. There are no advantages and disadvantages to either one. It's a, quote, dying debate that no one wants to talk about anymore, unquote. Anterior approaches to the hip have some advantages, such as a lower dislocation rate. There is decreased muscle damage. It is not truly muscle sparing. The downside to an anterior approach includes increased risk of femur fracture, increased risk of early femoral stem loosening, increased radiation exposure, increased wound complication rate. It is not extensile, and there's injuries to the lateral femoral cutaneous nerve, which can produce numbness over the anterolateral thigh. The benefits of the posterior approach, which is the gold standard and has a long track record of success, includes the fact that it's extensile. The downside to the posterior approach includes increased risk of dislocation. You do split the gluteus maximus and reflect the short external rotators. It is a bit more trauma. Femoral stem fixation. There's a trend to cement more femoral stems, especially in females over the age of 70. The cemented stem is a static interface, provides immediate fixation, and to have you think of it as grout. There's non-cemented stems, very popular in the United States, which we refer to as a biologic interface. It has immediate macrofit fixation from friction. It's faster in the operating room, but it has a higher risk of femur fracture and thigh pain. At the Academy meeting in Chicago this year, there was a topic of discussion that we are putting too many non-cemented stems in older patients who are at increased risk for femur fracture, and it was recommended that we return to consider cement fixation in patients over than 70 years of age. One of the problems that was identified, however, is we have generations of orthopedic surgeons now who have never cemented a femoral stem because the pendulum moved so far to non-cemented during the last 20 years. Whereas most hip replacements in the United States have non-cemented stems, most knee replacements are cemented. The trend, however, is towards more non-cemented knee replacements. Only 10% were non-cemented knee replacements in 2019. Technology-assisted surgery. So we went through multiple phases throughout my career. I started out with minimally invasive hip and knee replacements. It found its place in medicine. We moved to patient-specific cutting guides and implants. That was proven not to provide benefit. We moved to computer navigation, which has found a role in orthopedics. We often use intraoperative x-rays. We're now up to robots, virtual reality, and artificial intelligence and machine learning. The question is, will technology like robots improve survivorship, improve function, and decrease the rate of revisions? Will it increase the percentage of the forgotten knee? Robotic-assisted arthroplasty improves the precision of your preoperative plan and the final execution of cuts. Old machines milled out bones, but newer machines position cutting jigs, and you make the cut, or some of the machines will make all of the cuts for you. The unanswered question, however, is whether technology-assisted arthroplasty translates to better outcomes or survival. Technology adds cost to cases and will ultimately have to prove its value. The assertion that alignment predicts success remains unproven. Paramount to good execution is your plan. So what is your plan? You have to make some decisions. Historically, in knee replacement surgery, we would always use the mechanical alignment. It was the gold standard, a perpendicular cut of the tibia to the long axis of the tibia. But there are now choices to be made. In the normal knee, the tibia is in 3 degrees of varus, and the femur has a compensatory 3 degrees of valgus. And there's a difference between single leg stance on your left and double leg stance on your right. So in a double leg stance, a mechanical axis with your tibial cut perpendicular to the long axis of the tibia is the most appropriate cut. But the slide on your left, in a single leg stance, a cut in 3 degrees of varus all of a sudden becomes perpendicular to the loads in the mechanical axis of the leg. An American Board of Orthopedic Surgery article chosen this year for maintenance of certification, published in 2019, was a randomized study done in Seoul, Korea, of 975 robotic knee replacements and 990 conventional knee replacements. I found this article interesting in that the American Board of Orthopedic Surgery chose it for orthopedic surgeons' reviews. 96% of robotic knee replacements, 95% of conventional knees were available for follow-up at an average of 13 years post-surgery. No patient was done under 65 years of age. No patients were done with a body mass index over 40. The results demonstrate a slight decrease in outliers in positioning and no differences in patient-reported function or loosening of components more than 13 years post-surgery. In preparing for this talk, I came across this on LinkedIn, and it was a great debate on LinkedIn over this last week. Here you have an X-ray of a patient's knee on the left, clearly put into varus, and the question was this on purpose? Was it by accident? And the physician reports the patient has manageable discomfort after a few days of skiing. How do we reduce infection? Preoperative antibiotics are most important. We want to reduce minor breaches in the operating room with sterile technique. We wear isolation suits, but that is not known to decrease risk of infection. It protects the surgeon, but not so much the patient. We use antibiotic cement in diabetics, and there's a trend right now looking at extended oral antibiotics in obese patients. Word of note, don't give any corticosteroid injections to a knee replacement, arthritic knee replacement patient if they anticipate having a knee replacement done in the next 3 months. There's been an association with increased risk of infection. There are 37 to 100 trillion microbial cells living on the human body, depending on what you look at. The goal is to reduce the microbiome to reduce contamination of the wound. Chlorhexidine baths night prior to surgery, morning of surgery, are used to decrease colonization. We also use Nosen to decrease nasal decolonization. Blood conservation strategies have also been shown not only to reduce bleeding, but also reduce risk of infection. Tranexamic acid is widely accepted at this time to help reduce blood loss and infection rates. A 3-minute betadine lavage prior to wound closure is now widely accepted in reducing surgical site infections. We'll do this before closure and hip and knee replacements. Dressings, we often apply silver-impregnated hydrocolloid dressings that are routinely used. Silver is both bacteriostatic and bactericidal. Additionally, we're starting to use closed incision negative pressure drains on patients who are at high risk. And the picture on your right shows a closed incision negative pressure drain. Those might be considered to be used for obese patients, people on steroids, immunocompromised, or for any other reason. Outpatient arthroplasty. This is a picture of my cousin Griffin, whose parole officer said he could have his hip replacement, and this is him coming home on same-day surgery. In properly chosen patients, there is no increased risk. We use multimodal analgesia. There's been a paradigm shift in orthopedics such that we want to keep well patients with the well, and we don't want to send them to the floor and hospitalize them if possible. But there's many factors that have allowed us to move to outpatient arthroplasty. Common questions include, can I have both of my knees replaced at the same time? The answer is yes. However, you have increased risks of mortality in 90 days and pulmonary embolus. Will I set off a metal detector? Yes. How often should I follow up with my surgeon? It's variable. Some surgeons say never, call me if there's troubles. Other surgeons say yearly, but the general consensus is every 3 to 5 years. Do I need to take antibiotics prior to dental procedures? And the answer is, for most orthopedic surgeons, yes. So here's a board question. 65-year-old woman, she had a knee replacement. Should she have postoperative antibiotics? What the literature says at this time is we cannot recommend for or against antibiotic prophylaxis prior to dental procedures. But most orthopedic surgeons, my partners and myself, have seen infections immediately following dental procedures. And for that reason, most of us will recommend antibiotic prophylaxis for life. I'm going to skip this patient here on time constraint. So what are our goals? I cannot take credit for coming up with the shared goals. This is called the triple aim. Improve the health of populations, improve the patient experience, reduce the per capita cost of healthcare. This was coined by Donald Berwick, the Institute for Health Improvement. He was director of the Centers for Medicaid under President Obama. When we talk about factors that affect outcomes, we must not be ignorant or complacent about the structure of the United States healthcare system. We're great scientists and we're very good at what we do, but there's increasing evidence that the structure of our healthcare system is a factor that affects outcomes. My ask of you today is that you continue to advocate for the health of our patients and our community and participate in healthcare reform. And I'll conclude with my favorite comedian and amateur philosopher, Trevor Noah. And with that, I'll entertain any questions.
I'd like to thank Dr. Baranko. We have a question from Dr. Crosland.
Want to lose weight if you are morbidly obese or if you're obese. It's the super rapid rate loss, I think, that you were referring to as an increased risk for infection. Those people will have a decreased total lymphocyte and a decreased albuminemia. And if you have those two things, hold off on operating.
That is a great point by Dr. Crosland. So what we're looking at now is more anthropomorphic measurements rather than strict body mass index. In the weight loss, rapid weight fluctuations actually can increase a patient's risk. But if a patient is on a structured weight loss program, it is definitely to their advantage to lose weight prior to surgery.